I'm Dr. Lucinda Bateman. Today we're going to talk about getting the right diagnosis, fibromyalgia, MECFS, and associated conditions. I want to start by saying fatigue can occur in many settings in medicine and in life. This is from a slide I used at a physician education conference, particularly for mental health providers. And this is to illustrate that almost every condition can contribute to fatigue if that is out of control or escalating. On the left, you can see many kinds of mental health conditions that might cause brain fog and fatigue and sleep disorders. Grief, depression, anxiety, bipolar disorder, and abuse and eating disorders. They take a big toll on your body. On the right are numerous medical conditions just by general category: neurologic, malignant, autoimmune, infectious, cardiopulmonary, metabolic, endocrine. All of those conditions can present as fatigue, brain fog, achiness, and so can medications. Up at the top are some more simple things we don't always attribute to fatigue: deconditioning, being chronically stressed, being exhausted and run down, chronically poor sleep, nutrition, chronic pain, all of those things, and especially if there more than one are present in your circumstance. And honestly, it's important to remember that our stamina and our fatigue can decrease with age. So you need to be realistic about your energy levels based on all of those factors. In this slide, we are listing more specifically medical conditions that can contribute to chronic chronic fatigue or widespread pain. And I've specifically listed some that might not be first line in the differential diagnosis, and it might help to just think about them. So we've listed them here, and you could take this page and take it to your primary care physician or do your own research and just make sure that you've been carefully screened for illnesses such as these that might contribute to chronic fatigue or widespread pain. I'd like to talk next about how we make a diagnosis of fibromyalgia. What is fibromyalgia? Well, this is what it looks like. This and feels like to the patient who filled out this pain diagram, and this patient. So those are two somewhat different distributions of pain, but a pain diagram can often communicate to a medical provider what might be going on and what the underpinnings of your pain might be. The first diagram was more generalized pain. In this diagram, you might be able to recognize that this patient has a peripheral neuropathy or damage to the nerves in the legs and the arms, as well as irritable bowel, headaches, and pain in the low back as well as in the upper torso. Fibromyalgia is not primarily a musculoskeletal disorder. Fibromyalgia is a nervous system disorder that creates musculoskeletal pain, along with global pain amplification, physical and mental fatigue. It might be considered a neuroimmune or neuroinflammatory disorder in the future. Unfortunately, the exact cause of fibromyalgia is still unclear, but we do know a lot about it. It's characterized by chronic, widespread, amplified pain and other sensory signals that communicate between the body, the spinal cord, and the brain. There are two terms doctors use that you should be familiar with. The first is hyperalgesia, and this means pain is amplified. And allodynia is a term that means a sensation that's not really a pain is amplified to the point that it feels like pain. So squeezing the arm instead of pressure begins to feel like pain. In 1990, the American College of Rheumatology proposed these diagnostic criteria for fibromyalgia. And this was based on a large study of patients in a rheumatology setting. And they were able to show that if the pain was chronic, meaning at least 3 months in duration, widespread and generalized, involving all 4 quadrants of the body and the spine, and was characterized by tenderness, and they defined tenderness as having pain upon pressure in at least 11 of the 18 tender points. That this was a good way to distinguish fibromyalgia from the other types of rheumatologic conditions in the clinic. So it's not just low back pain. Fibromyalgia is a phenomenon of generalized pain amplification and other sensory amplification. And this article noted that fatigue, brain fog, and sleep disturbances were present, but they weren't required to make the diagnosis of fibromyalgia. Here is a diagram showing how this patient's pain involves all 4 quadrants of the body and the spine. And here's a diagram showing the 9 paired tender points that were discussed in this paper, and a patient should have at least 11 of the 18 tender points to meet the fibromyalgia criteria. This only has to occur one time, so tender points do not have to be reproduced over and over, and in fact tender points can change depending on many factors. So using the 1990 ACR criteria, epidemiologic studies have been done, several large studies. These studies suggest that 2% of all adults meet these criteria. More common in women, 3 to 4% in adult women, and less common in men, but present, 0.5 to 1% of adult men. That's a large number of people who meet criteria for a disease that causes so many symptoms. Fibromyalgia was kind of in the dark until there was the development of drugs for the treatment of fibromyalgia pain that were approved by the FDA. Interestingly, this started before that when the drug Neurontin, the drug we commonly call gabapentin now, which was used as an anti-seizure drug, it became apparent that gabapentin was very helpful for neuropathic pain and some other types of pain such as fibromyalgia. Unfortunately, the FDA sued that company for off-label marketing. In other words, the company was not allowed to promote use of the drug for anything other than the studies that were done to get the FDA approval. What followed was the development of a similar drug called Lyrica, and then there were 2 drugs that are antidepressants that also raise norepinephrine along with serotonin, Cymbalta and Savella, that were approved by the FDA for the treatment of fibromyalgia. Well, this was great because millions were spent by the pharmaceutical companies to teach the public and to teach primary care physicians about making a diagnosis of fibromyalgia. Of course, it was to sell their drugs, but because fibromyalgia was so poorly understood, it was also a benefit to all the people with fibromyalgia. It even made the Dr. Oz show in 2013, the disease doctors miss most, fibromyalgia. By 2010, some of the same authors of the 1990 fibromyalgia criteria suggested new fibromyalgia diagnostic criteria that didn't require the use of tender points. With these criteria, patients were initially asked to identify a number of pain areas out of 19, as you can see on this diagram. So they just check these varied pain areas, and if the widespread pain index reached 7, or an alternate diagnosis, that was the first step, then a symptom score is calculated. And this adds the score of chronic fatigue, unrefreshing sleep, cognitive complaints, and then the fourth category has changed several times, but let's just say it was more the picture of severity of multiple symptoms. And each of those is given a score, 0 to 3, added together with a possible of 12. So the widespread pain index was added to the symptom score, and if it was 7 for the widespread pain and 5 for the symptoms, that meets the criteria for fibro. Or alternately, if there were fewer pain areas, 3 to 6, you could still meet fibromyalgia criteria if your score on the symptom score was more than 9. I know it sounds confusing, and maybe it's a little harder for doctors to remember, but it does illustrate and help you see the multi-system nature of fibromyalgia and all the symptoms that it creates in addition to the widespread pain. So fibromyalgia is an illness of central sensitivity and sympathetic overdrive. That's your fight. The sympathetic nervous system is your fight and flight response. So when you combine that central or neurologic sensitivity with the fight and flight, you can have many common manifestations with fibromyalgia. Now, these can also occur alone, but they're very common as part of fibromyalgia. And in general, if you reduce the hyperalgesia of fibromyalgia, generally, most of these problems follow as well. Migraine, pain in the TM joint, numbness and tingling, restless legs, irritable bowel, irritable bladder, pelvic pain, cardiovascular symptoms, dry eyes, dry mouth, and sensitivity to light, noise, and chemicals all fall under this mantle. So who gets fibromyalgia or any kind of chronic widespread pain that meet these criteria? Well, it can occur in men, women, and children, but it's most common in women. And there may be susceptible individuals. Maybe you have a family tendency to developing this. This is under study. We do know that it is a familial pattern. I think there's a strong element of sleep deprivation or being chronically sleep disturbed that may predispose to developing chronic widespread pain. And it's not uncommon for people to be emotionally stressed or overloaded. And those things go together, feeling stressed, missing sleep, having your adrenaline pumping going. We know that people who are just physically depleted and overextended can also develop fibromyalgia. And in that setting, many insults or triggers can occur that might set it off. Hormonal changes, viral infections, inflammatory or autoimmune conditions, even a car accident or physical trauma can precipitate and trigger fibromyalgia, along with other factors that we don't understand. Fibromyalgia is more prevalent in people with anxiety or PTSD, bipolar disorder, maybe in depression as well. Think about those illnesses as raising your fight and flight chemistry and making it more difficult to sleep, creating those risk factors. We also know that people who suffer chronic pain in one area of their body are more likely to develop fibromyalgia. People with hormone deficiencies, nutritional deficiencies, chronic sleep deprivations from sleep disorder, and also people who have an inflammatory or autoimmune disorder may be more likely to develop fibromyalgia on top of it. The prevalence of fibromyalgia varies a lot depending on what group you look at. We talked about the general population, but if you go to an internal medicine or rheumatology clinic or people who have irritable bowel, you'll see that it's 13 to 50% of those people meet fibromyalgia criteria, meaning they have generalized pain in addition to the medical problem that took them to those clinics. The prevalence in people with type 2 diabetes may be as high as 20% fibromyalgia. And if you look at one uncommon autoimmune disease called Behçet's syndrome, 80% of those people develop symptoms that qualify for the fibromyalgia criteria, in addition to their primary disease that's an inflammatory and autoimmune disease. So there's really plenty of evidence to support a diagnosis of fibromyalgia, and these really led to the drugs that were approved for fibromyalgia. Images on functional MRI, analysis of spinal fluid showing elevated pain neurotransmitters, the many studies looking at the disruptions of sleep in fibromyalgia and MECFS. And more recently, there's some very interesting research that shows fibromyalgia patients may have evidence of small fiber nerve damage called small fiber polyneuropathy. If you look at this diagram, you can see that the small nerves out in the skin, you'd almost have to enlarge this, but tiny little filaments go out into the surface of the skin to detect danger and sensation, cold, sharp feelings. These nerve signals go up to the brain and process the brain in the brain and come back down and tell you to move your hand or to make a change. But these sensory nerves are small fibers, so the very little tips that initially sense the danger are very tiny hair-like nerves, as opposed to the nerves that take the signal back to the brain. These are also called C fibers, and they're in the skin, but they also are the type of fibers that regulate your organs and the autonomic nervous system. And this is a diagram from a paper published in Pediatrics by Dr. Ann Oaklander and her colleagues at Harvard. The picture on the left, and I hope you can see this, but all the tiny little nerve fibers are present, and the picture on the right, B, shows the absence of these tiny little nerve fibers. That is what we call small fiber neuropathy. Now, this can come from many different factors: diabetes or prediabetes, hypothyroidism, autoimmune diseases, nutritional deficiencies, autoimmune diseases like celiac disease, and then post-infectious syndromes, the toxic effect of alcoholism, and many other factors that seem to be damaging to these tiny little frail nerve fibers. So if you look in the not fibromyalgia, but in the small fiber nerve injury description, you can see that small fiber nerve injury may result in pain and autonomic nervous system dysregulation, amplification of all the senses and pain, dry eyes, dry mouth, lightheadedness, problems with temperature regulation, gastrointestinal symptoms, sexual dysfunction, urinary dysfunction. Sounds familiar, doesn't it? It sounds very similar to many of the symptoms of fibromyalgia. The frustrating thing with small fibers is that it's difficult to detect the damage to small fibers. So doing a typical neurologic exam with reflexes and coordination and strength sometimes can be normal. Even some sensory exams can be normal if you don't take the time to be very careful to assess diminished heat and cold sensation or vibratory sensation, which can be subtle. And the usual tests we do in neurology, EMGs, nerve conduction, and MRIs, unfortunately can't show small fiber neuropathy. The last thing I want to say about fibromyalgia is to remember that there are many other kinds of pain syndromes: osteoarthritis, cervical or lumbar disc disease, TMD, headaches, irritable bowel, peripheral neuropathies, the presence of which can be aggravated by fibromyalgia. So it's important to understand if you have a more global, widespread pain issue, as well as understanding how to dig in and address the specific underlying local regional pain syndrome. Well, next I'd like to talk about myalgic encephalomyelitis, chronic fatigue syndrome, also called MECFS, and talk about how we make this diagnosis. Let me give you a little historical background, because it has been a journey. Things have changed, and a little bit of historical perspective may help us understand better. The term chronic fatigue syndrome was first published in 1988 in a paper that proposed new criteria to explain this emerging illness. It was also meant to replace the term chronic Epstein-Barr virus, or chronic EBV, and just describe a chronic post-viral syndrome that might be caused by numerous pathogens and not just Epstein-Barr virus. Since then, chronic fatigue syndrome, or CFS, has been known by other terms as well. Chronic fatigue immune dysfunction syndrome, or CFIDS. Outside the US, the term myalgic encephalomyelitis was used especially for the more severe cases. And some people just call it a post-viral syndrome or a post-infectious fatigue syndrome. Now, these are not new illnesses. They're worldwide, multicultural. And myalgic encephalomyelitis is the term that has gradually moved forward to have more prominence. Now, after that 1988 publication called the Holmes publication, 6 years later, there was another set of criteria for chronic fatigue syndrome published. These were called the Fukuda Criteria because the author was Dr. Fukuda. These new criteria required that in order to get a diagnosis of chronic fatigue syndrome, the patient should have clinically evaluated, unexplained, persistent, or relapsing fatigue of at least 6 months duration, and that results in substantial reduction of function. Then, in order to complete the diagnosis, at least 4 of the following 8 criteria had to be present: post-exertional malaise, impairment in memory or concentration, unrefreshing sleep, muscle pain, joint pain, headaches, sore throat, and tender lymph nodes. This started out as a pretty good research criteria to understand this grouping and work toward subsets or understanding different ways of manifesting these criteria. But unfortunately, we got stuck using these criteria for a couple of decades. It became more clear, too, that patients with fibromyalgia, if they had significant fatigue and if their illness impaired normal function, could also meet these criteria because of the fatigue, post-exertional escalation of pain, cognitive issues, sleep, muscle, joint pain, and headaches. I mean, we talked about those symptoms, and those are scored in the 2010 fibromyalgia criteria. So there's been some controversy about whether these criteria are specific enough, but it is notable that using these criteria, epidemiologic studies showed that there were at least 1 million people in the United States who met these criteria, and that if the criteria were broadened slightly and changed a little bit, that maybe up to 4 million people would meet these criteria. So it points out how important and common these multisystem illnesses are, but doesn't lead us forward to being more specific in identifying subsets. In 2003, the Canadian consensus criteria were published. These were criteria that were meant to be more descriptive and clinical and to be more detailed in the presentation of MECFS. And the biggest problem with these criteria was they weren't published in a major journal and weren't easily accessed unless you already knew they existed. So they basically were ignored or not acknowledged by the larger medical community. One of the important things I want to talk about today is that in 2015, a report was published called Beyond MECFS, Redefining an Illness. This was the result of a 1-year-long evidence-based review of the literature and a large effort to decide, based on the evidence, what the presenting core symptoms of MECFS are in order for clinicians to do a better job of making this diagnosis and recognizing the illness. This can be found at this website. There's a short document called the Key Facts. There's a 20-page clinician guide, but the full report is about 300 pages. And it's excellent. What we learned from that report is that there are more than 1 million people in the US who meet these criteria. It's amazing that as many as 80 to 90% have not received a diagnosis based on research. Those who do get a diagnosis may have struggled for years to get that diagnosis. 75% more than a year, and 30% more than 5 years to get their diagnosis. It acknowledges that doctors have been skeptical about the serious nature of this illness, and they have many misconceptions about it, especially that it might simply be a psychological illness, which is not true. We aren't teaching medical students and doctors about this illness, and the IOM report recognizes that we are lacking in this area. So the purpose of the Institute of Medicine, or the IOM report, is to improve clinical diagnosis and care for people with MECFS. It's aimed at physicians to identify the common core symptoms of MECFS, focus on the illness manifestations that we might be able to measure and objectively prove, and they're simplified to increase the chance that doctors will remember them and use them to make a diagnosis. So here they are, the MECFS clinical diagnostic criteria. And it's important to start out by saying these core criteria are required to make the diagnosis. These symptoms must be moderate to severe and frequent in occurrence, at least 50% of the time, and not otherwise explained by another condition. Number one is impairment in function related to exhaustion or fatigue, and this can be physical and cognitive, but the key is impairment in function, in normal function. Number two is post-exertional malaise. This is basically illness worsening or illness relapse after attempts to engage in activity, and this can be physical, cognitive, or any other kind of activity. Number three is unrefreshing sleep, and we will talk in our sleep lecture about how unrefreshing sleep and many ways that dysregulated sleep can lead to unrefreshing sleep are present. And then patients must either have cognitive impairment or orthostatic intolerance, and many patients have both. These are the core criteria that are common to all people with this illness based on the evidence-based review. Now, many other symptoms can occur, and we know this is true. Pain, all kinds of pain, immune or infection manifestations, neuroendocrine dysfunction, and these descriptions mirror the Canadian criteria, but they're not present in everybody and not at every stage of disease, like the core criteria. Now, MECFS can be diagnosed definitively after 6 months of supportive care and diagnostic investigations, but it can be a working diagnosis from the onset. And it's expected that physicians will complete a differential diagnosis and appropriate workup of symptoms, including referral to specialists, and will be directed by healthcare providers. All other identifiable illnesses should be diagnosed and treated, and this working diagnosis can be maintained until the definitive diagnosis can be made at 6 months. And it's expected that supportive care and management will be provided from the onset of illness. Now, the purpose of our talk is not to talk about why these illnesses occur, but rather how to recognize them and make a diagnosis. But I would like to say that many infections, not just Epstein-Barr virus, are associated with a post-viral fatigue syndrome. This includes many in the herpes family of viruses: Epstein-Barr, cytomegalovirus, herpes simplex virus, varicella zoster virus, that's the chickenpox and shingles virus, and others in the family. Parvo B19 specifically, is associated with in some people with lingering symptoms. Enteroviruses, mainly Coxsackie and echoviruses, can cause respiratory, gastrointestinal, and neurologic disease and have long-term sequelae or consequences. Flaviviruses, Giardia, Mycoplasma and Chlamydia, and of course Borrelia, which causes Lyme disease. These have all been implicated in a small percentage of patients going from the acute infection to having longer lingering symptoms. And unfortunately, there's no smoking gun. We haven't found one infection that seems to explain it all at this point. The most important and exciting things are recent research breakthroughs that we can't detail in our talk today, but it is across these fields. Metabolomics, this is looking at the cellular metabolism, the products of cellular metabolism that demonstrate low cellular energy production, especially in patients with MECFS. Studying the microbiome and how altered gut flora and the impact on the immune system might be playing a role in MECFS and Fibro. Studying more about inflammation and the immune system, and we have evidence of abnormal cytokine patterns, autoantibodies, natural killer cell dysfunction, and others that are under study. And there are some very interesting advances in genetics and genomics looking at familial risk, mutations, and I'm very hopeful for the future that we will be able to be more specific and subset illnesses within these debilitating multi-system illness complexes. So in review, and it's difficult to simplify, but patients who develop fibromyalgia only, the symptoms are somewhat easier to treat and manage. They respond better to lifestyle interventions. The post-exertional consequences are usually more mild and manageable, more characterized by pain amplification. Of course, it's primarily based around pain and tenderness, but it's a pain that responds to many interventions and medications, even improving sleep. Sleep, mental health, and fatigue are also manageable, and they're not comfortable, and they can be very life-changing. This is a difficult illness, but the symptoms kind of morph together and respond to medications, respond to lifestyle changes, and the most important thing is that low-impact exercise helps all aspects of fibromyalgia, and as long as the pain is respected and managed. We use a measure in our clinic called Hours of Upright Activity, HUA. And on average, my fibromyalgia patients report 10 to 12 hours of upright activity tolerance, which is reduced from normal and makes it difficult to carry out an 8 or 9 hour workday. But it's a little different than what we see in MECFS. Patients with MECFS have symptoms that are more debilitating, more difficult to treat. The post-exertional malaise can be much more severe and prolonged. And they're more likely to have orthostatic intolerance. And the key to management is activity reduction or pacing, and exercise can easily worsen all aspects of illness and cause extended relapse. Now, I wish they could be divided like that, but it's not that simple. Sometimes people meet criteria for both, and that means that they have widespread pain and debilitating function as well. So I've seen people start with a post-viral fatigue syndrome without much pain, and over the years evolve into a syndrome characterized by widespread pain and meeting fibromyalgia criteria. I've also seen people with fibromyalgia who, after exposure to certain risk factors or travails, develop MECFS and are much more ill. So really, these are descriptions that help us understand maybe the way the illness is presenting, to keep that in front of us and to give us treatment targets. But eventually, we may be able to be a lot more specific in the way we diagnose these illnesses. From my standpoint, I like to understand, and you should try to understand, how you respond to low impact exercise, because if low impact exercise starts to free you and help you and improve your illness, it's more like fibromyalgia. And if low impact exercise continues to set you back, then you might want to be thinking more about the processes that underlie MECFS. This is just a diagram to sort of help us understand how complicated and overlapping these illnesses are. Now, this is just based on my opinion, not data, but you can see there's a real large circle of people who experience chronic fatigue and chronic pain. Within that are the people who meet fibromyalgia criteria in the orange or the yellow circle. The real small orange circle is ME. I think that the IOM criteria are a little broader than that, a little bit more like the Canadian criteria. But you can have fibro and not meet the MECFS criteria. You can meet all the criteria, and the more of these syndrome criteria you meet, it's very often that it's associated with more severe illness and more debilitation. So we have a long way to go before we can be specific, but we have enough information to really dig in, make a diagnosis, and start to help people function better and have improved symptoms. And before I close, just here's the little reminder of the four-legged table. Pacing and management of activity is always primary, and then the 4 table legs rest solidly on improving pain, restorative sleep, good mental health, and being able to reduce deconditioning as much as possible. That's that back table leg. And those are the 4 pillars that really help balance the tabletop and reduce unwellness and fatigue. And then remember orthostatic intolerance. If that's present, then that's going to be an important core part of supportive management as well. I wish you good luck with your pursuit of education, your discussions with your primary care physicians and others, and hope that you will be able to benefit from some of the other Bateman Horne Center classes: widespread chronic pain, activity tolerance pacing and post-exertional malaise, understanding and treating sleep disturbances, understanding and treating cognitive impairment, and recognizing and managing orthostatic intolerance. Good luck.